Good afternoon for the Chinese participants and good morning for the European participants. My name is Yihai Cao, and I'm a professor working at the Karolinska Institute, Stockholm, Sweden. I specialize in cancer research and cancer therapy. It is my great privilege and honor to chair the Sino-Europe Anti-Cancer Summit, organized by the China Anti-Cancer Association. The short name is CACA, and co-organized by BeiGeneEurope Health. This conference is supported by an independent educational grant from BeiGeneEurope. We're very pleased and honored to invite 4 leading experts from China and Europe. They are presidents of the China Anti-Cancer Association, the European Association for Cancer Research, the European Cancer Organization, and the Sharing Progress in Cancer Care. We would like to take this opportunity to thank the organizers and the contributors for organizing this exciting summit. We would also like to thank all audience for participating in this exciting conference. So prior to scientific program, let us warmly welcome the Vice President of the China Anti-Cancer Association, Professor Ying Wang, to welcome all participants and give opening remarks. Please, Professor Wang.
Thank you, Professor Cao, for the introduction. Dear distinguished guests, ladies and gentlemen, good afternoon and good morning. It's my privilege to give a welcome speech at the opening ceremony of the 2023 Sino-Europe Anti-Cancer Summit. Firstly, on behalf of China Anti-Cancer Association, I would like to extend my sincere thanks to EACR, ECO, and SPCC for your cooperation and contribution to this leading cancer summit. And also thanks to BeiGeneEurope Health for jointly hosting the summit with CACA. Secondly, I'm very pleased to take this opportunity to introduce who we are and what we do. CACA is the largest and the most influential cancer society in China and was founded in 1984. Currently, we have over 650,000 individual members and 133 professional societies. CACA plays a leading role in cancer prevention, treatment, research, and education in China. In recent years, CACA has made significant progress on academic exchanges, including hosting the largest scale cancer congress annually. This November, we will host the 2023 Chinese Congress on Holistic Integrative Oncology in Tianjin. We warmly welcome all of you to China and attend the Congress. Last year, in collaboration with AACR and ASICO, we successfully hosted Sino-US Anti-Cancer Summit. Today, we are very excited to bring together the world-leading cancer leaders from Europe to have this virtual meeting. It is extremely a good opportunity to provide us with a unique platform to share the top-level dialogue on cancer management, to exchange the latest achievements in clinical practice and research outcomes. Meanwhile, it will facilitate the collaboration between China and Europe to achieve our common goal of reducing cancer burden globally and benefit cancer patients worldwide. United will be stronger. Let's work together to make cancer history. Thank you very much.
Thank you, Professor Wang, for introducing CACA to us and the welcome remarks. Now, we will begin the keynote speech section of this summit. Let's welcome the first speaker, Professor René Bernards, who is the President of European Association for Cancer Research. Abbreviation is EACR. Professor Bernards is best known for his research work on cancer genetics for personalized treatments of cancer patients. His accomplishments include the development of MammaPrint, the first gene expression tool that has been successfully used for diagnosis and the clinical management of breast cancer, and of a vector system that can be used to identify potentially powerful combination therapy for effective treatment of cancers. Some of these therapeutic combinations have now been approved by the FDA for clinical use. Professor Bernards is a member of the Royal Netherlands Academy of Sciences, the US Academy of Sciences, the American Academy of Arts and Sciences, and a fellow of AACR Academy. The title of his presentation is Activation of Oncogenic Signaling as a Cancer Treatment Strategy. Please, Professor Bernards.
Oh, thank you very much, Professor Zhao, for the kind introduction. I'm going to share my screen with you, if I can. See where let's see. Is this now visible to you?
Yes.
Good. So I'm going to talk about activation of oncogenic signaling. And I would like to point out that my connection to China is that I also have a research group at the Shanghai Jiao Tong University of Renji Hospital. So my disclosures are that I will be talking about a drug that is made by a company called Lixti Biotechnology that supports my research. So we are all aware of what we call the hallmarks of cancer, which means that oncogenic signaling makes that cells no longer need growth factors, have limited proliferative, limitless replicative potential, and are insensitive to anti-proliferative signals. This is what oncogenic signals do to make a cancer cell grow. But at the same time, we know that these oncogenic signals activate stress responses, DNA damage stress, oxidative stress, mitotic stress, to name just a few. So cancer cells do not strive to maximize oncogenic signaling because too much oncogenic signaling will lead to a hyperactivation of these stress responses that are detrimental to cancer cells. So cancer cells look for the optimal level of oncogenic signaling rather than the maximal level of oncogenic signaling. Of course, in conventional cancer therapy, we try to inhibit these oncogenic signals to make sure that these limitless proliferative capacity is blunted. But we all know that inhibition of oncogenic signal leads to resistance where the signals come back due to secondary mutations. So what I'm going to propose to you is a very different approach. Instead of inhibiting oncogenic signaling, we will deliberately hyperactivate the oncogenic signaling, which will lead to this activation of these stress responses to the extent that the cells are unable to proliferate. So if you were to combine a drug that hyperactivates oncogenic signaling together with a second drug that inhibits the stress responses, potentially we could get very effective cell killing. And this combination of hyperactivation of oncogenic signaling combined with the inhibition of the stress responses, we call a paradoxical intervention, because it's the counterintuitive approach to treating cancer. Instead of inhibition, we try to further activate. And this is what we have described in the past as a potential cancer treatment strategy in the journal Molecular Oncology. So how do we activate oncogenic signaling further? There's a major phosphatase in the cell called protein phosphatase type 2A, PP2A for short, that inhibits GSK3 beta-catenin signaling. It inhibits the PI3 kinase AKT signaling, and it also inhibits the MEK/ERK MAP kinase pathway. So that would suggest that if you were to inhibit PP2A, you would activate all these three major signaling pathways in a cancer cell. And that's indeed what is possible with a small molecule inhibitor of PP2A called LB100. And remarkably, even though PP2A is a very promiscuous phosphatase that has many targets in the cell, it turned out that in a phase 1 clinical trial, LB100 had a very modest toxicity profile, which was very unexpected at the time. So PP2A inhibition indeed is anti-proliferative. As you see here, in a panel of colon cancer cells, we see that LB100 leads to a slowdown of proliferation, in spite of the fact that, in fact, the oncogenic signaling is increased. As you see here, the levels of phosphor-ERK in these colon cancer cells is increased. The levels of phospho-Jun are increased, even though there is already mutations in BRAF and KRAS in these cells. But you also see that the stress responses are activated. DNA damage and the unfolded protein response are here super activated by this drug LB100. So it's indeed true that LB100 does two things. It super activates oncogenic signaling, it activates the stress responses, and that leads to a slowdown of proliferation rather than an increase. And I argued earlier that potentially you need to find an inhibition of the stress responses to make this treatment really very effective. So to address this question of which of the stress responses do we need to inhibit, the postdoc that worked on this project, Matti S from Brazil, made a small library of 164 compounds where he then treated cells with these 164 compounds that target these various stress responses and asked, is there any compound that becomes more toxic in the presence of LB100 than in the absence of LB100? Because a drug that becomes more potent in the presence of LB100 is a potential drug to synergize with LB100. And the results of that small compound screen is shown here, where we measure the area under the curve for presence and absence of LB100. And the more down a drug is in this graph, the more toxic it is in the presence of LB100. And what you see here, that there's two targets that stand out, CHEK1 and WEE1, in the two colorectal cancer cell lines where we performed this screen. So CHEK1 and WEE1 inhibition is potentially synthetic lethal with hyperactivation of the mitogenic signaling. Matthias also did an unbiased CRISPR screen to ask which genes become toxic in the presence of LB100. And he found again that the WEE1 kinase was a hit in the screen, which you also saw with the compound screen. And for that reason, we focused subsequent synergy experiments on the combination of a WEE1 inhibitor named adavosertib and the LB100 PP2A inhibitor. And here you see a number of colorectal cancer cells that we treated with adavosertib in increasing concentrations and LB100 in concentrations that increase. And you see here that in a number of colorectal cancer cells, the synergy is remarkable because the drug combinations are far more effective than the individual single agents. That is also seen in short-term proliferation assays where we test a combination versus the single agents. So the drug combination appears to work very well, and it also works well in other cancer types like pancreatic cancer and cancer that is particularly difficult to treat, cholangiocarcinoma. So there seems to be very little context dependency of this particular combination of the PP2A inhibitor and the WEE1 inhibitor adavosertib. So how does this work? We filmed cells as they went through mitosis, and time-lapse filming allows you to follow cells, individual cells, as they go through the cell cycle. So in a typical asynchronous cell population, cells will spend on average maybe 45 minutes in mitosis and then go on to the next cell cycle. So this is the typical pattern of cell mitosis of asynchronously growing cells that spend some 45 minutes in mitosis and then go on. If we treat with LB100, we see that a lot of cells enter into mitosis but are unable to leave. The same for adavosertib, they enter earlier because adavosertib inhibits mitotic entry. So if you inhibit, or let me say V1 inhibition, V1 inhibits mitotic entry, so the V1 inhibitor adavosertib allows cells to enter mitosis earlier. And the combination is particularly detrimental because the cells enter early into mitosis but are never able to leave anymore. And the reason that they are unable to leave is that if you look at the chromatin of the cells during mitosis, it is completely what we call pulverized. We cannot recognize individual chromosomes, as you can see in a normal mitotic figure. That leads us to believe that these cells have massive DNA damage that prevents a normal mitosis from happening, and the cells die apoptotic death, as seen by caspase positivity. So why is it that the cells die? The cells that are treated with LB100, to make a long story short, suffer massive DNA replication stress. They are positive for a mitotic marker called phosphohistone H3, but they are positive with a between 2N and 4N DNA content, meaning they are in mitosis with incomplete DNA replication. And that leads to the mitotic death, because a cell that enters mitosis without having replicated the DNA completely will die by mitotic catastrophe. Now, a key question, of course, is whether this treatment is tolerable by animals. You see here the results of 3 different colon cancer PDX models, patient-derived xenografts from colorectal cancer patients that were treated either with the monotherapies or the combination. And what you see in the combination-treated animals is that the tumors are barely detectable, and you see that what is left of the tumor consists mostly of inflamed stroma and dead tumor tissue, and only small rims here of viable cancer cells are available. So very few viable cancer cells remain after this treatment. And most importantly, the animals do not lose weight, which is a good surrogate marker for the level of toxicity that we observe of this combination. In other models, like a cholangiocarcinoma model, we see the same little single agents effect and very good combination effects in the absence of weight loss. So this is all very good. But as we know, how all cancers are able to develop resistance to therapies. So we were interested to learn how cancer cells develop resistance to this paradoxical activation of mitogenic signaling. So to begin to address this, we treated cells with LB100 and performed a CRISPR screen to ask, how do cells become resistant to LB100? By knocking out genes or by overexpressing genes. So CRISPR-A is a system where we overexpress genes to ask what makes cells more vulnerable to LB100. And there we saw as a top hit MYC and members of the MAP kinase pathway. You see a number of oncogenes here, MAP kinase components, PI3 kinase components, and MYC, saying that increase in oncogenic signaling makes the cells more sensitive to LB100, because that's the problem of LB100. It increases mitogenic signaling that is toxic to cells. If you now increase mitogenic signaling more, that becomes even more of a problem to the cells. Conversely, if we reduce mitogenic signaling in a CRISPR knockout screen, like knockout of beta-catenin will suppress Wnt signaling, now the cells become relatively resistant to LB100. So if we put these data together in a string diagram, we see that the genes that control the sensitivity to LB100 are primarily centered around MYC and around beta-catenin, saying that Wnt pathway signaling and MYC signaling are major determinants of sensitivity to this drug LB100. If we now validate this in NMYC amplified neuroblastomas, because I told you MYC is a major driver of sensitivity, we ask the question, are MYC amplified neuroblastomas that have very high levels of MYC, are these cells exquisitely sensitive? And to do this, we went back to a cell line that I made back in 1986 that over a neuroblastoma cell that expresses very high levels of the MYC protein. And sure enough, we found that high levels of MYC expression also in the neuroblastoma cells creates vulnerability to this drug LB100, validating this concept that across cancer types, MYC is a determinant of response. Now, how do cells then become spontaneously resistant? And this is the last topic that I would like to address in the few minutes that I have left. We see that we can make cells spontaneously resistant to the combination of LB100 and adavosertib by long-term culturing in the presence of these drugs. But what has now happened in these cells? The most striking thing we see is that these cells that are highly aneuploid, SW480 colorectal cancer cells, as one example, is highly aneuploid, has about 75 chromosomes, but the resistant cells have a near diploid chromosome number, telling us that the cells have normalized their karyotype as a resistance mechanism. And this normalization goes further. If you do single cell RNA sequencing of the parental SW480 cells and the cells that became resistant to LB100 plus adavosertib, we see that a number of mitogenic signaling pathways are downregulated. MYC signaling is down, E2F signaling is down, and Wnt beta-catenin signaling is down. And that tells us that the cells, to become resistant to this hyperactivation of oncogenic signaling, have managed to downregulate their oncogenic signaling. And that asks for an important question. Are these cells that have now become resistant and have downregulated oncogenic signaling, are these still cancer cells? There's a lot of oncogenic signaling that has disappeared by the loss of cancer-causing chromosomes. And the experiment that Matti S did was, to me, one of the most beautiful experiments I've seen in a long time, where the parental SW480 colorectal cancer cells formed tumors in mice. The cells that were resistant to the combination of LB100 and adavosertib had downregulated oncogenic signaling to the extent that they were no longer able to form tumors. So the conclusion for my work is a very simple one. Hyperactivation of oncogenic signaling is a potentially viable cancer treatment strategy as resistance selects for cells that have a reduced oncogenic phenotype, which is exactly the opposite of what we see when we inhibit oncogenic signaling, because then we select for cells that have increased oncogenic phenotype. They have gained a KRAS mutation on top of a BRAF mutation in the case of melanoma, or otherwise they have reactivated the inhibited pathway. But by overactivating oncogenic signaling, you force the cells to evolve towards a less oncogenic phenotype. So we call this process tumor suppressive resistance, and I'm very excited to test this concept clinically later this year. So I'll stop here and tell you that most of this work was done by a Brazilian postdoc, Matheus Henrique Dias, collaboration of René Bernards' lab and Alberto Villanueva in Spain. And here are the people that have funded my research. And I thank you very much for your kind attention.
Thank you very much, Professor Bernards, for this very exciting, inspiring lecture. Professor Bernards provides an outstanding example of groundbreaking basic research changes, clinical practice, and eventually being beneficial for cancer patients. So it's really inspiring. So let's welcome our next speaker, Professor Daiming Fan, who is the president of the China Anti-Cancer Association. Professor Fan is world's famous cancer scientist and a clinical oncologist. He is also a great friend of mine. We met some years ago in China and also in Sweden. Professor Fan serves as a president of the Asia Pacific Digestive Week Federation. He is a member of the Chinese Academy of Engineering, a foreign member of the National Academy of Medicine, US, a member of the French National Academy of Medicine. He specializes in digestive diseases by doing both clinical and basic research. He has received numerous prestigious awards and prizes for his outstanding achievements, including the first awardee of the prize of French National Academy of Medicine, Sevier, the 2019 Masters of WGO Award. As an editor-in-chief, he has authored more than 200 books in gastroenterology and oncology research areas. He has published more than 700 peer-reviewed articles in international journals, including the top international journals. He serves as the editor of 15 international medical journals. Well, we can't talk about his scientific achievements all day long, but I will stop here. Let's welcome Professor Fan to deliver an exciting lecture. The title of his lecture is Development of Holistic Integrative Management of Cancer in China. Professor Fan, please.
Dear Mr. Chairman, dear my colleagues, ladies and gentlemen, I'm Daiming Fan, the president of CACA. I'm very pleased to participate in this international conference to share our latest contribution on holistic integrative management of cancer. Just right, the Professor Bernards, the presentation is very, very impressive. Also, I did some research works on basic science and clinical works of cancer in China. But today, I would like to tell you the new strategy or to development of a new CACA guidelines for cancer prevention and treatment in China. As you know, China bears heavy burden on cancer. According to the statistics, around 1 out of the 4 cancer patients in the world is from China. About 1 out of 3 patients who died from cancer is from China. There are about 8,000 patients from China who die from cancer every day. While the 5-year survival rate of cancer patients in the Western country is about 70%. It is most 40% in China. Standard diagnosis and appropriate treatment is the key to improve overall outcome of cancer. Therefore, guidelines play an important role in cancer prevention and treatment. One cannot completely copy the guidelines from other countries because treatment of the same cancer should have a different focus in different countries. For example, liver cancer ranks the second cause of death in China. The main etiology in the Western country is HCV, while in China, it is mainly caused by HPV. Hepatitis C is curable with antivirus therapy. So HCV, HCC is theoretically curable. However, it is difficult to cure the hepatitis B. Hence, the key to treat hepatitis-induced liver cancer lies in etiology. In terms of the gastric cancer, it is closely related to the Helicobacter pylori. The preventive treatment requires HP eradication. The infectious rate of HP in China is over 60%, but it is not the case in the Western country. If we eradicate HP when treating the tumor, it can bring better results, and it is not only contributed by the oncologists, but also by the GI experts. As for the esophageal cancer, which ranks the fourth, it is mainly esophageal squamous cell carcinoma in China. But in the Western country, it is mainly esophageal adenocarcinoma. In China, it is mostly related to the dietary habit, for example, consuming too much nitrate or excessive smoking, alcohol, and HPV infection. While in the West country, it is mostly caused by reflux disease. Therefore, in China, we cannot adopt the guideline, especially for esophageal adenocarcinoma, adenocarcinoma treatment in the Western country. Due to the current situation of unbalanced medical resources and non-standard cancer care in China, it is necessary to develop new guidelines on cancer management that adhere to the concept of whole course holistic integrative management and operable in clinic with accessibility at the grassroots level. From 2022 to 2023, CACA organized over 13,000 leading experts to develop the CACA guidelines for holistic integrative management of cancer. The guideline contains more than 8 million Chinese characters and was published in both English and Chinese with 46,500 continuing medical education questions and answers. It includes 113 guidelines covering 53 types of tumor in the tumor chapter and 60 techniques in the technical chapters. The 53 types of tumor in the tumor chapters covers 97% of Chinese tumor patients, which divides into 5 categories, including prevention, screening, diagnosis, treatment, and rehabilitation. The technical chapter divides the guidelines into 6 categories, including overall assessment, supportive treatment, diagnostic techniques, therapeutic techniques, organ protection, and basic research. Adapting previous guidelines, but emphasizing the uniqueness of Chinese physicians, it becomes a standardized guideline system with both Chinese characteristics and international perspective. China's attitude towards cancer may be complementary with the Western. We advocate the concept of a holistic integrative medicine and emphasize multidisciplinary treatment to holistic integrative management, which means to establish a multidisciplinary working model to formulate an individualized and integrated healthcare plan and to achieve an optimal effect using a holistic view and integrative regimen. The growth of a tumor is related to the field, the environment, and natural force of the human body, whether A seed can grow into a tree depends on not only the seed itself, but also the whole environment. There is a great amount of essence in traditional Chinese medicine that we cannot forget. For instance, we found that arsenic trioxide, which was used in GCM 2,000 years ago, can treat acute myelocytic leukemia, the APL, with great effect. Now, it is used worldwide. Another example is artemisinin. It is extracted from plants and can be used to treat malaria. And Mrs. Yu too, from China, has won the Nobel Prize because of it. Now, it is also found that artemisinin can reverse not only the bacterial drug resistance, but also the tumor cell drug resistance. Besides, GCM indicated 2,000 years ago that microbiome can treat disease, also cancer. If chemotherapy does not work for tumor and multi-drug resistance occurs, we don't need to deal with tumor cells. We just need to change the intestinal microbiota, and the drug resistance of tumor cell can be reversed, can be overcome. Thus, our guideline has integrated the GCM with Western medicine. Foreign guidelines emphasize more on diagnosis and treatment, but ours are different. As I mentioned before, CACA guidelines for holistic integrative management of cancer focuses on the whole process of prevention, screening, diagnosis, treatment, and rehabilitation. As you know, 1/3 of a tumor can be prevented by changing lifestyle. I am a gastroenterologist. Most of the time, 260 endoscopic procedures were performed in my department per day, but most of endoscopic screening for cancer are negative. We need to perform tens of millions of endoscopic screening for cancer in China. If we stratify and focus on the high-risk population, we will get more efficient results. Also, the follow-up for rehabilitation is very important after the treatment for cancer patients. CACA's 50,000 members will conduct a follow-up and provide guidance for their patients. For example, patients with lung cancer, which is caused by smoking, should stop smoking after treatment. CACA technical guideline for holistic integrative management of cancer is on the technique and how to choose the appropriate treatment for individual patients. It focuses on assessment, support, control, protection, and survival. The first is assessment. We should assess the patients before receiving surgery or other treatment. In China, around 50% of the cancer patients are anemic, but 92% of them directly undergo surgery and other treatment before without treating anemia. 70% of patients are malnourished, malnutrition, and 70% of them directly undergo surgery or other treatment before. We should treat the cancer patient rather than the patient's cancer. Thus, we need to perform whole-body assessment for patients in the future. Second is a supportive. After the assessment, we need to complement the insufficiency, such as nutrition and psychology, to make the patient be strong enough to undergo the surgery. Third is control. We should control the growth of a tumor cell rather than just kill them, because everyone has tumor cell, and they will only become cancer when growing into a certain amount. If we kill tumor cell, the normal cell will also be killed. Hence, many cancer patients die faster once get treated. Fourth is a protection, which means to protect the normal organ. A large proportion of cancer patients die from the damage of normal organ function, such as the damage of a kidney and the liver caused by the hyperkalemic calcium due to cancer or the treatment of a cancer. All kinds of treatment do harm to normal organ functions. Surgery is a mechanical damage. Chemotherapy is a chemical damage. Radiotherapy is a physical damage. Biotherapy is a biological damage. There is also psychological damage. Cancer patients are weak, and it will cause problem if we don't protect them. We have specially developed 15 guidelines on organ protection, including the protection of growth and development for pediatric patients and the fertility protection for adult patients. In CACA, there were 2 teams, one specializing in treating cancer, such as the Hepatic Cancer Society, and the other specializing in protecting the organ, named the Oncohepatology Society. And the 2 teams work together to treat patients with a good effect. Last is the survival. The prognostic effect does not only refer to the removal and the reduced size of tumor, and they are just surrogate endpoints. The primary endpoints should refer to the prolonging survival time and improve the quality of life. These 2 indicators can be used to evaluate which therapy and which doctor is better. The patient may die even if the tumor is cut out, and this is not the effect we hope to achieve. In the last 2 years, we have released and promoted the CACA guidelines nationwide. We have heard 64 different presentation sessions, not only to doctors, but also to the public, with a total of more than 1.3 billion online attendees. We have been learning from the foreign guidelines and get benefit. We should extend our sincere thanks to them. However, the MDT to heme model in CACA guidelines may reversely benefit to other country. The 5-year survival rate in foreign country is 70%. By adopting foreign guideline previously, the rate in China has reached 40%. However, the CACA guidelines will help us improve for the rest 60% and may provide references for foreign countries to solve their rest 35. So thank you very much for your attention. Thank you.
Thank you, Professor Fan, for this very exciting and informative lecture. This lecture provides a holistic view of clinical management of cancers in China by using integrative approaches. These integrative approaches likely, in my mind, revolutionize cancer therapy. Thank you. So let me introduce our next speaker, Professor Matti Aapro, who is the president of Sharing Progress in Cancer Care, SPCC. Professor Aapro is widely recognized for his achievements in numerous areas of oncology and supportive cancer care. He is the former president of European Cancer Organization, ECO, the former president of the Multinational Association for Supportive Care in Cancer, The short name is MASIC. He also serves as a board member of the Union for International Cancer Control, the executive board member of the International Society of Geriatric Oncology, and the board director of GenoLiner. Let me see, it jumps. Cancer Center, Switzerland. Dr. Aapro main interests include breast cancer, cancer in elderly, supportive care, and access to treatments. The title of his lecture is Improving Patient Itinerary. Welcome, Professor Aapro. Yes, we cannot hear you.
Okay, sorry for this technicality. And thank you very much, Professor Chow, for your kind introduction. And my special thanks, of course, to CACA for having invited me, along with two eminent colleagues from Europe, for this Sino-European exchange. It has been my pleasure to be a friend of CACA since quite a few years, as some of you remember that I was already working with UICC when you had the UICC Congress in Shenzhen in China, and I was one member of the Congress organizing team. Since then, we have been in numerous contacts. And SPCC has recently signed a memorandum of understanding with CACA, where we would like to share our experience and learn from your experience. I was asked to show that I have some collaboration with drug companies. Here's the slide. But the most important point is that, as you kindly mentioned, I also work for non-governmental groups like the European Cancer Organization, and Professor Charalambous is my successor. And I also work for not-for-profit entities, and these are the two ones that I will be discussing with you. But before I go to some examples of what we do and which we could share with all our friends in China, I'd like to mention something that is a part of the work of the patients that are within the European Cancer Organization, and that has been promoted by ECO, which is the European Code of Cancer Practice. Unfortunately, and as we have the pleasure of having Professor Charalambous with us, he's attentively listening to the fact that we might want to collaborate with CACA in order to translate this European Code of Cancer Practice for information for all of you, because this highlights the importance of the patient literacy, that the patient should understand what is going on so that the patient can ask the right questions and adhere to the treatment that is suggested. This is in some ways part of holistic oncology. What is SPCC? Sharing Progress in Cancer Care. We are an independent, not-for-profit organization based in Bellinzona in Switzerland. And our aim is to work together with many stakeholders, from industry to associations, for example, CACA, and also the American Society of Clinical Oncology, ASCO, and other organizations, where we have signed or are going to sign memorandums of understanding. And everything we do is free, online, for access by everyone in the world. And with today's techniques, we are starting to translate many of the webinars also in other languages than English, and this includes, of course, Chinese. We realize that the world is large, and we are based in a tiny little country in the center of Europe in Switzerland. And as you probably know, technically, legally, Switzerland is not part of Europe, even though we are geographically right at the center of Europe. In order to progress with our work, we have asked for support from many colleagues whose names are depicted here on the slide. We started with a European Scientific Advisory Board, and now we have advisors coming from all areas of the world. We still are lacking advisor from Africa. We are going to work on this in the near future. And it's my great pleasure to indicate that Hong Liu from Tianjin, China, is there supporting our ideas with the background of the work of CACA. And we are going to soon have the next Scientific Advisory Board meeting. We use, like all of us, different means of communication. They are indicated here. They are available in the traditional way on the web under the name Onco Corner, where all our webinars of the previous year remain available. And of course, we communicate via some so-called social media. Our journal, Cancer World, which is not a printed journal anymore, the world has changed, and we decided to invest the cost of printing into a bigger team of journalists so that we can cover the whole world, and we have now journalists from many areas throughout the world. So let me show to you some of the activities that we have been doing and are doing presently. No doubt that the whole world has now learned about artificial intelligence, which is a wording that I personally do not like, because it is just a way of not saying that this is computer managed work. It's not only care, work. And the intelligence behind that is human. It's the humans that program this so-called artificial intelligence. So we have been dedicating some webinars to this, and are going to have the last of the series as an online symposium very soon. An important area in which we do work is to try to improve the patient pathway. And we have been lucky to have support from a company to make a call for projects for the improvement of the pathway of patients with metastatic cancer. Many centers, this was unfortunately for legal reasons, available only for European centers. We are working on the idea of having something similar worldwide. We're winners of this grant, and the results of this work that started 2 years ago are going to be presented at the Advanced Breast Cancer meeting in Lisbon, Portugal at the end of this year. We are now approaching, once again, for legal reasons, centers only in some European countries, for asking them to present the projects for improvement of the pathway of patients with early breast cancer. And the decisions on who are the winners will be done by fall this year, and the projects will go on for the next 2 years. We are extremely happy to be working along with Professor Daiming Fan, who is a leader of holistic oncology. And of course, we have an interest in this. As you heard, I have an interest for supportive care for a long time. And we are developing a cancer pain so-called academy that should be happening in Rome at the end of this year. because there is a lot to be done and taught, and this is open to participants worldwide, provided that they can afford the flight to Rome. An ongoing activity has been to summarize breast cancer congresses that have been happening, and this is going to continue on request of the Scientific Advisory Board. We're also going to be soon summarizing cancer congresses in lung cancer, in prostate cancer, and in GI cancer. Data, the quality of data is essential. And this is something that we are going to approach with a program that you can see here on the slide. And we are discussing actually also with CACA on how we could interact. Cancer in the elderly is predominant in some countries in the world, and already in China, by numbers alone, you have a lot of patients with cancer above the age of 70, which is nowadays the artificial limit to speak of elderly patients. So we have different projects of teaching around this area with the International Society of Geriatric Oncology. And we have launched a task force on nutrition in geriatric oncology that should start working very soon. This is indeed an important topic, along with nutrition in general, as indicated by Professor Fan just a few minutes ago. We are not in research, but we recognize the importance of the advances which were so brilliantly shown by Professor Bernards. And we have had for years a meeting on molecular diagnostics and genomics in cancer led by Professor Gligorov and Professor Frédéric Pinot-Lorca. And this is going to happen again this year. And this is open as an online course to the whole world. And our specific collaboration in the near future with CACA is that we have a breast cancer in young women forum summarizing the activities of the breast cancer in young women meeting that was held last year with the friends in China. And we are very grateful that CACA is going to support this special initiative. We have some ideas of where we want to go. I cannot share them with you because I need the approval of the Scientific Advisory Board, which should be obtained very soon. And now, in a couple of minutes, I will talk to you about improving efficiency in cancer care, which is the work of All.Can International. All.Can International is a not-for-profit entity supported by many different groups and stakeholders that has subgroups all over the world, not yet in China, but near to China, in South Korea, and in the southern area of your part of the world in Australia. All.Can's purpose is to work all together in order to improve what is available. We are not there to help research, however important it may be, but we recognize that what is available, if it is used better, is going to be profiting many more patients. This is our vision, that also all patients are taken care of throughout the world. Patients first, all together, multi-stakeholder collaboration. With 4 different columns of work, 4 dimensions: partnerships, supporting the healthcare professionals, of course, using present-day technology and supporting the investments into other technology and opening the silos that exist. As you certainly know, in many countries, hospitals cannot communicate to each other because they use different methodologies in order to have their patient charts, which is absolutely unbelievable in a small country like Switzerland, for example. We have published several publications which are on our website on the data-driven for better cancer care, on measuring the improvements that we can bring to the health system, on achieving better efficiency through different examples that are available, unfortunately, only in English on our website. And I would like to finish my presentation by just attracting to your attention to our call for action, which is, in very simple terms, for those that can read English, there's some complex terms, but in very simple terms is that if we all work together, we will achieve a lot. And this is exactly what I'm very happy is happening right now as we have this dialogue between European stakeholders and CACA. Thank you very much for your attention.
Thank you very much, Professor Aapro, for your wonderful lecture and sharing the authoritative views of cancer management with us. We are very pleased to learn the broad international collaborations between SPCC and many other countries, especially China. Thank you. So let's welcome our last speaker, Professor Andreas Charalambous, who is the president of European Cancer Organization. He is also the vice chairman of the nursing department at the Cyprus University of Technology. He holds the position of adjunct professor at the University of Turku, Finland. So that's Nordic land, very good to see. He is the founder of a former president of Cyprus Oncology Nursing Society, a former president of European Oncology Nursing Society, the founder of a Cancer Nursing Fund, and the founder of European Cancer Communications Foundation. The title of his lecture is EU Beating Cancer Plan, a new EU approach to prevention, treatment, and care. Please, Professor Charalambous.
Thank you so much, Professor Chow, for this kind introduction. It is a great pleasure and honor to be with you and with your esteemed colleagues and friends from Europe and China. And thank you once again for the invitation to be part of this initiative. Before I start the presentation, some of my disclosures here, some of which you have already mentioned, and over the next 15 minutes, if this is possible, I'm going to be presenting a wide snapshot of the EU Beating Cancer Plan, which is one of the flagships of the European Commission in an effort to tackle cancer throughout 27 member states. So the EU Beating Cancer Plan, it's basically a political commitment which has been made in order to turn the tide against cancer and also to contribute towards a stronger European health union. And why do we place emphasis on tackling cancer? Well, the statistics provide the answer, I believe, because back in 2020, we had recorded 2.7 million people in European Union being diagnosed with cancer and 1.3 million dying from it. Among those, about 2,000 were young people. If today we take absolutely no measures, then by 2035, then the new cases of cancer will increase by 24%. And the paradox here is that although Europe represents only 10% of the overall worldwide population, it has quite a high percentage of the world's cancer cases. So cancer is it's a policy priority because it is not only affects the Europeans' health, but it also affects the society at large. So Europe's Beating Cancer Plan takes, let's say, a holistic approach, touching on the control and management of cancer across the entire disease pathway. So it emphasizes on prevention, early detection, diagnosis and treatment, but it also places emphasis on the quality of life of cancer patients as well as survivors, as more people are surviving cancer nowadays. And the EU Beating Cancer Plan is constructed on 10 flagship initiatives. I will only be mentioning these initiatives very briefly, otherwise we will not have the time for discussion. So the first flagship includes a new knowledge center on cancer, which will be launched within the Joint Research Center to help coordinate scientific as well as technical cancer-related initiatives at the EU level. As part of this initiative, we have launched as EU the European Cancer Imaging Initiative, as well as the European Health Data Space Initiative. The first initiative allows cancer centers around Europe to contribute annotated cancer images in this federated space, and these images can be later be used for research purposes. And in terms of the European Health Data Space, it's a data space which collects data from the 27 EU member states, and it gives also much more digital control of the patient over its data. In terms of flagship to the European Cancer Imaging that I just mentioned, it will basically serve as an EU atlas of cancer-related images, and it will provide access to hospitals, researchers, as well as innovators. And this is not an initiative that at the longer term will only benefit the European context, but it will have a global impact and potential value. Flagship 3 includes basically the efforts to introduce within the European context and allow the member states to extend existing routine vaccinations against HPV. But in this case, they should become gender-free for girls and boys in order to eliminate cervical cancer and other cancers caused by human papillomaviruses. As you can see in the image on your right, these are the countries with a gender-free vaccination policy in place, and the aim is to extend these to cover all 27 European countries. And the objective set is to be at least 90% of the target population to be vaccinated. In terms of flagship 4, the European Beating Cancer Plan will put forward a new EU-supported cancer screening scheme to help member states, ensuring that 90% of the EU population who qualify for breast, cervical and colorectal cancer screenings are offered by 2025. And as part of this flagship, a recent development which happened last November is to update the European screening guidelines, which screening guidelines also included prostate, lung, and gastric cancers for the first time. Of course, the update of these screening guidelines on a national point of view, it's always challenging in terms of the European Commission, and the Commission and the member states are working towards that way. In terms of flagship 5, the Commission will establish by 2025 an EU network linking recognized national comprehensive cancer centers in every member state. The initiative also will allow smaller EU member states to join other bigger countries and join these recognized national comprehensive cancer centers in order to for cancer patients to benefit the most regardless where they're living within Europe. And the cancer plan aims to ensure that 90% of eligible patients will have access to such centers by 2030. The new Cancer Diagnostic and Treatment for All initiative will help improve access to innovative cancer diagnosis and treatments. It will utilize the next generation sequencing technology for quick and efficient genetic profiles of tumor cells, allowing cancer centers, some of which we have just mentioned, to share cancer profiles and applying the same or similar diagnostic and therapeutic approaches to patients with comparable cancer profiles. Some projects financed under the EU for Health Work program have been launched under this flagship initiative already. Alongside the Genomic for Public Health project, the European Initiative to Understand Cancer, the uncan.eu, under the foreseen mission of cancer to increase the understanding of how cancers develop, will also help identify individuals at high risk from common cancers using the polygenic risk scores technique. In terms of flagship 8, funded by the EU for Health program, the Commission will launch the Better Life for Cancer Patients initiative. It aims to provide by 2022 a cancer survivor smart card to summarize their clinical history and facilitator and monitor follow-up care, including the patient's own experience. This card will be following the patient wherever he travels within the EU. And we're proud to say that the European Cancer Organization is the organization who has been assigned by the Commission this task to develop the smart care. In terms of flagship 9, the Commission established the Cancer Inequalities Registry, which is a registry aiming to record and follow inequalities across the EU, enabling the Commission as well as the national states to allocate resources where and when this is necessary and to which end. And the European Cancer Organization created a complementary tool which also tracks inequalities in cancer, but in elements which are not covered by the Cancer Inequalities Registries launched by the EU. And the final flagship is Helping Children with Cancer initiative, which is designed to ensure that children have access to rapid and optimal detection, diagnosis, treatment, and care. The funding of the plan comes from an unprecedented allocation of 4 billion euros by the European Commission, but it also funded by other comprehensive funding schemes such as Horizon Europe, Erasmus+, Digital Europe, just to mention a few. And the EU for Health program, which has been mentioned quite a few times, it aims at crisis preparedness, disease prevention, health systems and healthcare workforce, and digital, all which within the context of cancer. And the Europe Beating Cancer Plan has a specific roadmap for its implementation. It was launched back to 2021 and all the way to 25. It includes various stages of implementation, and all these implementation stages are complementary to the 10 flagship initiatives by the plan. And a few words about the European Cancer Organization. We have as our mission to reduce the burden of cancer, improve outcomes and quality of care, and we do so within a multidisciplinary and multi-professional context. We are a not-for-profit federation of member organizations working in cancer at the European level. We convene oncology professionals and patients to agree policy, advocate for positive change, and to be united voice of the European cancer community. We have over 40 professional member societies and over 20 patient advocates organizations consisting of the European Cancer Organization. Our vision is to create and develop ever-strengthening relationships between European organizations and the European cancer care community, and with other member societies, patient advisory committees, and focus topic networks. These are the values that we are working within: patient centricity, commitment to science, passiveness, inclusiveness, equality, fairness, openness, and transparency. ECO contributes heavily to the implementation of the EU Beating Cancer Plan through its active participation in many of its flagships, including, for example, projects such as Interact Europe, Protect Europe, Smart Care, also other projects which the European Cancer Organization participates as partners, such as Transition, Praise You, SOLAS, all of which contribute to the 10 flagships of the Commission. Of course, Europe's Beating Cancer Plan is just the first step, but the journey is quite long. And in this long journey, we can spare no one in the fight for controlling and managing cancer more efficiently and more effectively. And with this concluding remark, thank you very much for your attention.
Thank you very much, Professor Charalambous, for this wonderful lecture and sharing the impressive and ambitious EU Beating Cancer Plan. Let's hope the very best success of this EU Beating Cancer Plan. I feel a little bit privileged to be part of the European area. We are a little bit delayed, but let's start a panel discussion. I will ask questions according to the lecture sequence. We will then welcome questions from the audience. So let me first ask questions for Professor Bernards. Activation of oncogenic signaling for cancer therapy indeed seems to be very paradoxical and provocative. So what are the major concerns of this type of therapeutic approach?
Thank you, Dr. Tsao. I wanted to present some provocative research to highlight to this community that it is still very important to continue to invest in basic cancer research to make meaningful progress in the battle against cancer. There's an old saying in Holland that says, if you do what you did, you get what you got, which means that unless we make radical changes to the way we treat cancer, we're not going to make substantial progress. Yes. And my lecture really tried to make you think completely differently about cancer treatment, to think, why do we inhibit oncogenic signaling if the answer is invariably that the cancer cell will get the signal that you try to inhibit back? So we need to think unorthodox ways to beat cancer. And this was, I hope, one example of it. Yes, this is a potentially risky approach because many people would think that cancer patients could potentially have pre-malignant cells that could be stimulated to grow and therefore cause cancer rather than cure cancer. But I think the evidence for that is really not there. You know, there is a drug that is given to many millions of patients worldwide for the treatment of a bipolar disorder, a drug called lithium chloride. So lithium chloride is an inhibitor of an enzyme called GSK3 beta. Yeah. And therefore, it activates Wnt signaling, which is a major driver of oncogenic signaling. So Long-term lithium use in patients does not increase their cancer risk. In fact, it decreases their cancer risk. Epidemiological studies are very clear that people that take lithium for bipolar disorder are having less cancer risk. So my feeling is that activation of oncogenic signaling by drugs like lithium will not increase cancer risk. In fact, they may have the opposite effect.
So I do understand the point you try to make, because the drug resistance issue, your approach would resolve that part, whereas most cancer drugs will become resistant.
Exactly.
But however, most cancers already have intrinsic activation of oncogenic pathways, signaling pathways. Why would you have to make it super active or hyperactive for therapy?
The reason is that activation of oncogenic signaling activates stress responses in cancer cells. And the more you activate oncogenic signaling, the more the stress responses are activated. And stress responses can kill cancer cells. So hyperactivation of oncogenic signaling can lead to hyperactivation of stress responses and thereby cause cell death. And I think our data support that model. But of course, the most interesting and noteworthy aspect of this is that you can infect 4 cells to become less malignant, because that's the only way to escape this type of therapy. And that would be, if that works the same way in the clinic as it does in our animal models, it would be a major step forward.
Yeah, I really like paradoxical thinking of doing science or doing research. Thank you very much.
You're welcome.
Let me ask Professor Fan. I have many questions for you. However, I will ask some simple ones first. Let's see how much time we have. I will leave some as reserve questions. The first question is, what are the main differences between CACA guidelines versus European guidelines for cancer management in patients?
So, thank you very much. So if the audience is very clear to listen to the Dr. Bernards, Aapro, and Charalambous' presentation, I think they have answered the question in partly very well, I think. So how to speak that? In China, we have the very famous ancient philosopher, Lao Tzu said, the wise man is the one who knows what he doesn't know. If you use your hands, cannot solve the problem, such as the paradoxical mentioned by Bernards, you should use the brain and change the idea. So, as you know, in a different regarding the etiology of a cancer, in different country, often with a different situation, environmental, genetics, lifestyle, and so on. So, in the before, China has introduced the guideline from outside, such as ISMO and NCCN. So in Western country, you have got 70%. That means the 5-year survival rate is 70%. But introduced to China, we just get 40. So how to solve the rest 60%? We should change our idea. So we developed the CACA guideline, not just the focus on the diagnosis and the treatment of cancer at very stage, but also very importantly to move to the first step, the prevention and screening, especially and the survivorship management. That is for the tumor types chapter. The second one, even for the treat the patient with usually the ISMO and the NCCN, usually it's a focus on the cancer drugs, but our guideline not just the focus on the cancer, the drugs, but also the other, for example, surgery, radiation. Also, we especially pay attention to the overall assessment and supportive for support and recovery of natural force of patients. And also, before we treat the patient, use some remedy, but we pay attention to protection of cancer patients. Yeah, as you know, around 50% of patients die from not directly from the cancer, but from the normal organ, the failure. So so that is maybe this the differences, especially Chinese traditional medicine. Western medicine just introduced to China almost 200s. Before so many 1,000 years, we use Chinese traditional medicine also to treat the cancer with the good result. For example, arsenic nitrate oxide, it's a very good example. So after introduce the Western medicine, we forget the Chinese traditional medicine. So what is I would like to say that as a one side, we would like to learn from the Western guideline and also explore the possibility of a Chinese traditional medicine to put them together. So why we called our the guideline as a holistic integrative management? The integrative is to integrate the different remedy to form the individual the good plan and with holistic the whole body, from a whole body to the view to develop our the plan for the better result. So we don't know if I can explain that it's better, but the CACA guideline has been translated to English. We have English version and also Chinese version. So you can get freely from the CACA the homepage. It's so we welcome you to join us and to give us the suggestion. I'm sorry, this is really the big question, so we use a longer words to see. I'm sorry. Thank you very much.
Thank you very much. So we move on to Professor Aapro. So you mentioned that you do not particularly appreciate artificial intelligence. So what do you think the impacts of AI on future cancer management and care?
Well, thank you, Professor Chow. I do not appreciate the word artificial intelligence, as I said,
Yeah.
but because it is overused and it is used a lot by people that don't understand what they're talking about. There's no doubt that we are undergoing many areas a revolution because of the appropriate use of technologies in various instances. One of them being the use of methods that allow to do something that the human mind cannot do very easily. And I will just give the example of something that has been done by dermatologists for a long time, and no one was speaking artificial intelligence at that time. when you have a population at risk and you follow them for the potential development of malignant melanoma, they shoot pictures, and there is a system nowadays called artificial intelligence that looks at these pictures and says with high precision nowadays, this is something you have to take out. It is likely to be early melanoma. And this has, of course, decreased a lot the number of useless interventions. This is an example that I've been dealing with for a long time, as I was supporting the Swiss melanoma campaign and learned about this. And we speak with the radiologists. They do recognize that even in the best radiologists looking at standard chest x-rays will miss things that a reading by a computer will not be missing, because the human view is sometimes tired after a long day of work. The computer usually doesn't get very tired unless it gets a big bug. So I think that there's no doubt this is going to be of very big importance in many areas and will not substitute the highly well-trained surgeons and clinicians.
Thank you. So the question for Professor Charalambous: other non-European countries are also implementing new technologies and a larger data set of cancer prevention, early detection, accurate diagnosis, effective treatment, improvements, quality of life, survival. So what is so special about EU beating cancer plan from the rest of the world?
Thank you so much.
What are really new and unique aspect of EU beating cancer plan? Can you explain?
Thank you so much, Professor Chow, for the question. Of course, we do realize that, let's say, similar approaches are implemented in other parts of the world. However, what is unique in the case of the European Union is that it is not a single country. It's consisted of 27 different member states, and these flagships that I have just presented, for example, the European data health space, it allows all those 27 different countries to contribute their data in terms of patient data, images, and that creates a data space full of data that all the member states can benefit in terms of generating innovation, as well as improving control and management of cancer. The difference is also because those 27 member states are not the same. They're very diverse. So the health data space that is being built either by the images or other kind of information and data that are contributed to that space, it makes our ability to understand cancer better, to diagnose cancer better and faster, as Professor Matti was just mentioning. So we do feel that this is unique, but as I said in the presentation, this data space and initiatives will have and could have a global impact and not just a European impact.
Yeah. So I collected some questions from audience. The first question again to Professor Charalambous. I read it for you. What is the medical oncologist's perspective on rational surgical management of local advanced solid cancers? That's a question for you.
Okay, thank you, Professor Chow. I'm not a medical oncologist or a surgical oncologist by training. I'm a cancer nurse, as you have presented. However, surgery within the control and management of cancer has its value. in terms of the data, these data are not very, let's say, consistent across tumor types. So I would say that the surgical treatment in terms of locally advanced cancers cannot be generalized, but can be seen or discussed when we are speaking about tumor-specific conditions.
Yeah, so, thank you. Professor Aapro, there is a question for you. Is there any common interest between China and Europe in scientific relations before clinical trials?
Thank you, Professor Chow, and thanks very much for the question, whoever asked it. There is no doubt that there is insufficient cooperation between research groups throughout the world. I'm not speaking only between China and some European research groups, clinical research groups, as this is the question, but it is also true for the difficulties of cooperation that we have with other groups throughout the world. There are many reasons for that. Some of them are related to issues of insurance, as patients need to be insured in these studies. And others are just the fact that within Europe itself, it is difficult to get the groups of different countries to work together. So there's a lot to be done.
Thank you. Professor Fan, there's a question for you. What is the current state of collaboration between China and Europe? How would you see this evolving in the future?
That's a very good question. Today's the meeting is very important for us to collaboration. Before, we have a lot of collaboration between China and Europe. And in the individual collaboration between China and the different countries, they have a lot of, including the clinical trial and the research work and so on. Now, I am, because you know, the CACA is a member of the USCC, as I am the council member, the board of director for 2 terms. So I know I have many friends from Europe. So and we have a lot of collaboration in the future. And so, for example, the November of this year, we will have the National Congress of Oncology in China. It's the Grand Tour in Tianjin. So we will invite more than 100 we will invite the top leading experts from over 100 countries to join us, to give us a lecture, to discuss the collaboration, and also to do a lot of the collaboration. So among them, a lot of from the Europe. Formally, I would like to invite of you all 4, including Dr. Chow, you all 4 to join us if you are interested or if you have time. That means November the 17th. You know, this is meeting. It's a grand. The central venue is in Tianjin. In a different, we have a total 30 more province. Each province has the session with a different cancer type. So we invite you to join us. Thank you very much. Thank you.
Thank you very much for answering questions and also for your kind invitation. We look forward to Tianjin, especially from Sweden. November is very cold. I look forward to accept you.
So it's much warmer than Sweden. So you come to here. Right.
Thank you. So we have another question from Vice President of CACA, Professor Wang. Professor Wang, you want to ask directly?
Your
You
microphone.
ask-
So,
Oh, yeah.
yeah. Please switch on your microphone. We cannot hear you.
Can I hear me? Oh, okay.
Yes.
Okay, thank you, Professor Cao. I have a question for Charalambous. I think your topic for the European beating cancer plan is very interesting to me. And as a China Cancer Anti-Cancer Association, I think we have done a very similar work. And in China, we also face the same problem as Europe, because the cancer in China it's a really big problem, and the incidence of cancer have been increased 3% to 5% every year, and last year there were 4 million new cases and 2.8 million deaths. So that's a threat the life of people. It's really a serious social problem. Not only the health problem, it's a social problem. So CACA, as the state level organization, so we have the responsibility to decrease the cancer incidence and the mortality in China. So in order to do that, the president of CACA, Professor Daiming Fan, leading 13,000 experts to develop the CACA guidelines. And the CACA guidelines, we are popularized the CACA guidelines in the nationwide. And right now, we have finished more than 40 sessions, and the audience number is over 1.2 billion. So we think we have make progress to promote the CACA guideline. And my question is, so the Europe as the president of European Cancer Organization, do you have the plan to cooperate with CACA, and we can work together to improve the situation and to conquer the cancer, not only in Europe, but also in China? Thank you.
Well, Professor Yang, thank you so much for the question and for analyzing the strategy of CACA within the Chinese context. Of course, my last slide in the presentation, it mentioned that the EU Beating Cancer Plan is just a first step, and the journey to tackling, controlling, managing cancer, it's quite long and challenging and very much demanding. Of course, in doing so, nobody can be effective or efficient on his own. So the more collaborations we establish with other parts of the world, I think will be beneficial in contributing to the better understanding and the better control of the disease. So from a European Cancer Organization perspective, we would be interested to discuss with you in ways we can materialize that collaboration further in the near, of course, in the near future.
Yes, thank you. Thank you very much.
Thank you both. And we have now a question from the audience. A scientist from Pakistan would like to ask orally, speak to Professor Fan. Yes, please. Are you online from Pakistan? I don't know.
Pakistan. It's a far away, maybe, right?
Maybe I don't know his name, but well,
I have saw the question. Hey, what her question is? Yeah.
no, I haven't seen that question, but
Okay, right.
he or she want to ask you verbal. We barely hear you. Can you speak up or your microphone?
It's my pleasure to ask about this conference that Sino-Europe as a vaccination of.
Can you increase the voice because it's very difficult to hear you?
Yeah, it's. I think so. There is some sort of problem of listening or there, but I have a fully volume up about speaking of my microphone. Maybe there will be a bit problem here, but I just want to ask you.
Yes,
Hello?
it's better
Are you
now.
listening?
Yes, we hear you. Continue.
This is that the cancer is more prevalent than fatal disease. Now its prevalence is just reduced due to world powers are doing better for the treatment of this disease. So this in common countries, just like the developed countries in Pakistan, so its prevalence is too much high in breastfeeding, non-breastfeeding mothers, and especially the growing below poverty of early poverty women's girls. So they have no any sort of knowledge. What sort of preventive measures or informing measures Sino-Europe and Europe collaboration is going to elaborate this disease in this country? I just elaborate or want to elaborate the discussions about this sort of thing that some sort of informative and discussed forums have to be developed to make knowledge to the people, especially women, non-feeding women in our societies in Pakistan, the areas, Bangladesh, especially in China, and collaborative countries in these areas. So yeah. I just want to ask about this sort of thing.
Yes, thank you very much. I guess the connection a little bit, but I do hear something. I guess in Pakistan, people usually do not have the same knowledge as Europeans, maybe in China, for cancer management. So you want to share the knowledge, ask Professor Fan to share knowledge to people, to experts in Pakistan. So Professor Fan, can you answer this?
That is a very good question. So the Asian country, so maybe the situation is especially the natural environment and the lifestyle, maybe in genetic. Also, it's almost the same as the Chinese people. So we would like to share with you the CACA guidelines very much. So now so in China, the China government, we have One Belt, One Road, the plan. And also as a doctor or medical organization, we would like to collaborate with you very much. So we, our CACA guidelines are, it's a Chinese version and also the English version. You can use the English version. And also we have initiated in Yunnan province. It's your neighbor province. So they organized the translate the CACA guidelines in different cancer with a different language. Now they are doing, so after the translation, we will send that to your country, including Pakistan. So you can contact with our organization CACA by the CACA.org.cn. So welcome you. Thank you very much.
Thank you both. And we have a last question from audience. The question is to Professor Charalambous again. CACA would like to prefer to the EU beating cancer plan. I would like to ask you how to adopt the EU plan in China. What is your opinion?
Thank you for the question, and thank you for the person asking the question. Well, the simple answer will be it's not easy, because the EU beating cancer plan, it did not rise on 2021 on its own. There was a background preparatory work which reflected the needs of the member states, but also taking into consideration what the real problem is, what is preventing effective screening services being put in place. So I would say that of course, the EU beating cancer plan has been developed basically and primarily to reflect the needs of the 27 EU member states. So one cannot take the plan in its totality and just drop it in another region or part of the world and be efficient. It needs quite, I would say, a significant preparatory work in order to make the different points of the plan, for example, the 10 flagships, to be more relevant to the area or part of the world that you are trying to apply the plan. I'm not saying that it cannot happen, but it will require work to make it work in a new environment where the needs, and as Professor Fan mentioned earlier, cancer is not behaving in the same way in different parts of the world. And this is something, it's the simplest thing that we need to be taking into consideration when we are writing policy, and that policy will reflect clinical practice.
So thank you very much. There are many more questions, but however, due to time limits, we have to stop here. So we will have a couple of minutes for concluding remarks. I will say a few words first. Thank you all for the panel for this very exciting discussion and your presentation. For the audience, if you have any scientific question or other questions related to speakers, please contact the experts or host organization. We will find a way to address your questions. So after listening to presentations from panel members of the CACA and the various European cancer organizations, my personal feeling is that we need to strengthen our scientific and also authoritative collaborations in combating cancer disease, which is one of the main causes of mortality in both regions, as you already heard. So I do believe that we have complementary technologies, experiences, therapeutic interventions, diagnostic tools, and cancer care in both areas. Therefore, collaborations in cancer research area would be synergistic and beneficial. And we do need each other to combat the common disease already heard. For this reason, I propose, if we can form a joint new anti-cancer organization between China and Europe. This new organization, I don't know the name yet, but I was thinking probably can be called Europe-China Anti-Cancer Association, CACA. So you already have a CACA, you put E before the CACA. I mean, I leave you to decide. The overarching goal of CACA is to exchange knowledge, technology, joint funding to support collaborative projects, exchange basic scientists, clinical oncologists from both regions, joint decision-making for cancer prevention, diagnosis, therapy, care, focusing on the most difficult issues related to cancer, and training younger scientists for the future. I have briefly exchanged this idea with Professor Fan, and he gave full support for this idea. So I just say a few words on this. Now we invite the panelists one more time to conclude by one or two sentences, each of you, to the audience. We start again with Professor Bernards. Just one or two sentences.
Thank you. I would just like to say that it was a pleasure to meet everyone. And I'm certainly in favor of more European-China collaboration. As you have already seen from my laboratory in Shanghai, I have already started this. And I look forward to future collaborations with the Chinese cancer research community.
Okay, thank you. Professor Fan?
In response to Dr. Chao's suggestion for that to organize the CACA, the CACA will strongly support this. So this meeting is very wonderful. It is the first, but I don't think it's the last. So we will continue to do this. So welcome to China. As I'm staying in Xi'an today, so it's also I work here. So my foreign friends told me one has not been to China until he has been to Xi'an. You know, Xi'an is a very ancient city, terracotta here, that is a nice world wonder. You know, as an ancient capital, it is lasting more than 1,000 years. That means the history, and with 13 dynasties. So, I mean, we're coming to China not just for the cancer collaboration, but also establishment of our friendship to contract the golden strategy, the bridge, golden bridge between China and Europe. Thank you very much. Thank you.
Thank you, and we look forward to visit Xi'an. Professor Aapro? Oh, he already left, I guess. Yeah. So Professor Charalambous?
Thank you, Professor Chao. Also, it has been a pleasure and honor to be on this anti-cancer summit together with all of you and share views and perspectives. Also, we are in favor of cultivating and strengthening the collaboration between China and Europe. And as a concluding remark, I would say, coming from a policy-driven organization, I do feel that with a better understanding, the better tackling, and the better treatment of cancer, we also need policy to make the change much more efficient and effective, and a change that will be embraced by everyone in the regions we are discussing about. So yeah, looking forward for the collaboration. Unfortunately, I cannot be personally in China due to other commitments, but I look forward to meet you in another occasion.
Thank you. So today we have had a very successful the joint Sino-Europe Cancer Summit. 4 leading experts from China, Europe provide us the cutting-edge knowledge and the state-of-the-art technologies for combating cancer. We thank all speakers for their tremendous contributions to this wonderful meeting. Supported by medias, the online broadcast reaches to, I was informed, million audience. Wow, I've never been in a meeting like this. Thank
How
you.
many, I'm sorry, how many
More than 8
participants?
million. More than 8 millions.
No,
More than
it's,
8 million.
sorry,
How many-
sorry, Dr. Cao.
Yes,
Yes, the number is renewed, and the final number now
yes.
is over 11 million.
Oh my
Oh,
God.
12.5, sorry, over 12 million, over 12 million.
That's more than the Swedish entire population, I can tell you, in Sweden. Very exciting, very impressive. We thank all audience around the globe for participating this very inspiring and exciting meeting. I hope that all participants enjoy this high-level cancer forum and benefit from the conference. Finally, thank you all for your participation to make this event a great success. We are looking forward to further discussion between China and European professionals in the near future. Thank you very much. We end up
Thank you.
the conference.
Thank you. Thank
Thank
you.
you.
Thank
Thank
you.
you.